Hello, it's me, Professor Kemper. Welcome to another riveting lecture on head, ears, eyes, nose, and throat. Here are those wonderful student learning objectives, what we're learning from this lecture today. And so because we're transitioning into the head, ears, eyes, nose, and throat assessment, I really want you to think about function of those systems first. We want to ask ourselves, what is the body system supposed to do here? Because if we can normalize figuring out the normal function of something, then it's really easy for us to recognize any abnormal findings. Our head, it helps protect our brain, which our brain helps with all functions. So we're really thinking about neurologic function, we're thinking about symmetry, pain, like headaches. Then eyes all about vision, and then neurologic function. We have visual acuity, peripheral vision, pupil response, which also tells us about our brain function. So when we're assessing eyes, we're also assessing the brain. Ears are responsible for hearing and also balance. So problems here might show up as hearing loss, dizziness, or vertigo. Our nose, the nose is involved in airway function, also olfaction, which is our sense of smell. It also plays a role in filtering and humidifying air. Throat consists of our mouth and our pharynx, and it's essential for breathing, swallowing, speech. We're also assessing for infection, airway issues, and also hydration status. So when we are performing our head, ear, eye, nose, and throat assessment, instead of memorizing the steps, we really want to think about the function of those systems and what would it look like if that function was impaired. So we're starting with the subjective portion of the head assessment. So this is all about what the patient is going to tell you. So we're thinking about screening for neurologic and vascular issues here. So we start with headaches. This is one of the most common complaints. And for this, we're going to use a structured approach. So onset, when did it start? Location, where is the pain? Duration, how long has it lasted? Severity, how bad is it on a scale of 0 to 10 or whatever pain scale you're using. Triggers, what brought it on, do you think? So we're recognizing patterns here. Is this chronic versus sudden, mild versus severe? A red flag here would be if you hear the patient say, this is the worst headache of my life, we really want to think about a hemorrhagic stroke. History of any head injury or trauma. We want to ask about any past head injuries. It's important because it can lead to long-term neurologic issues or chronic headaches. Even something from years ago can still be relevant here. Dizziness and lightheadedness or syncope, we want to clarify what that patient means when they're saying these things because they're often used interchangeably. So we want to ask, do you feel like the room is spinning? So that would indicate vertigo. Or are you feeling faint? Have you had actual loss of consciousness? So this is going to help us differentiate between neurologic, cardiac, or vestibular causes. History of migraines or neurologic conditions. We want to ask about diagnosed conditions like migraines, seizures, or any stroke history. We also want to ask about auras, triggers, frequency. This is going to help us identify patterns and any risk factors. And whenever we have head complaints, we want to always think of, is this expected or chronic, or is this new and concerning? So now we're moving on to subjective ear assessment. Remember, ears are responsible for hearing and balance, so we're screening for both. So hearing loss or changes, we want to start by asking about any changes in hearing. We want to clarify, is this happening in one ear or both? Is this been sudden or gradual? Any gradual hearing loss, it's often age-related, while any sudden is really a red flag. Tinnitus, which is ringing in the ears, we want to ask about this. Any ringing or buzzing or humming sounds, it can be associated with hearing loss, noise exposure, or certain medications. Remember, it's subjective, so the patients may describe it differently. Ear pain, we want to ask about this. When the onset, severity, associated any symptoms like fever or drainage. Ear pain can also be referred pain that comes from the throat or jaw, like TMJ. We want to ask about any drainage from the ears, any fluid coming from the ears, the color, and odor, because it can indicate infection or potentially tympanic membrane rupture. Asking about history of ear infections or surgeries, because past history is important. We want to see if there have been any recurrent infections, which can lead to hearing loss, structural changes. We want to ask about any procedures like tubes or surgeries. The use of hearing aids. This can help us assess baseline hearing and identify any communication needs. We want to also check if they are functioning properly. And then exposure to loud noises. This is a big one and it's often overlooked. We want to ask about any occupational exposure, if they utilize music, especially headphones, because chronic exposure can lead to hearing loss. So red flags here, any sudden hearing loss, severe pain, or drainage. Now we're moving on to subjective eye assessment. Remember, the eyes are not just for vision, they also help reflect neurologic and systemic health. So vision changes, we want to start by asking any changes in vision. We want to clarify blurred vision, double vision, also known as diplopia, partial or complete vision loss. Any sudden vision loss is really an emergency, so we want to act on that immediately. The use of glasses or contact lenses, we want to ask about corrective lenses. It can help us understand, again, their baseline vision, and if any changes are new or expected. We also need to know this if we're planning on utilizing a visual acuity exam. Eye pain, redness, or discharge, we want to ask about discomfort or visible changes. Thinking about infection like conjunctivitis or inflammation. And the type of discharge really matters. Is it clear versus thick versus purulent? Any light sensitivity like photophobia. This can indicate an infection, inflammation, or neurologic irritation, and it's often overlooked. Any history of eye diseases like glaucoma, cataracts, macular degeneration. And then the last eye exam, and this is going to give us a sense of preventative care and monitoring of chronic conditions, because regular eye exams are especially important in older adults and patients with diabetes. So we are always thinking, is this gradual and expected, or is this sudden and concerning? So those red flags: sudden vision loss, severe eye pain, or new double vision. Now we're moving into the subjective assessment of nose and sinuses, and we want to think about our function here again. So this is airflow, filtration, and a sense of smell. So nasal congestion or obstruction, we want to ask if the patients feel like it's blocked or congested, one side or both. Is this constant or intermittent? This can point to infection or allergies or any structural issues like a deviated septum. Rhinorrhea, which is a runny nose, we want to ask about nasal drainage. It's important here to clarify color. Clear can indicate allergies or a viral infection. Yellow and green could be a possible infection. Epistaxis or nosebleeds, we want to ask about this and follow up with the frequency, severity, or any triggers. Common causes can include dry air, trauma, maybe they got into a bar fight, hypertension or bleeding disorders in some cases. Any sinus pain or pressure, we want to ask about facial pain or pressure, especially in the forehead where the frontal sinuses are, and the cheeks, which is where the maxillary sinuses lie. Pain that worsens when bending forward, it can often suggest sinusitis because of that pressure. And then allergies, we want to ask about seasonal or environmental allergies, common symptoms associated with this: sneezing, itchy eyes, clear drainage. It's one of the most common causes of nasal symptoms. And any changes in sense of smell. We want to ask about their ability to smell, any loss of smell. It can be related to an infection or neurologic issues. It's important because this is going to be tied to cranial nerve 1. And then clinical judgment tie-in. We always want to think, is this allergic, infectious, or structural? And our red flags here are going to be persistent unilateral symptoms, frequent nosebleeds, any loss of smell with the neurologic concerns. Now we're finishing the head, ears, eyes, nose, and throat subjective assessment with the mouth and throat. And so our function here is airway, swallowing, speech, and nutrition. So asking about sore throat or any difficulty swallowing, also known as dysphagia. We want to clarify, is there any pain with swallowing versus trouble getting food down? Dysphagia can indicate infection, obstruction, or neurologic issues. A red flag would be difficulty swallowing with drooling or any airway compromise. Hoarseness or voice changes, we want to ask about this. It could be related to infection, overuse of the voice, smoking history, and persistent hoarseness should always be evaluated further. Oral lesions, sores, or bleeding gums, we want to ask about any sores or lesions in the mouth. We want to also ask about bleeding gums. We're thinking about infection, poor oral hygiene, and nutritional deficiencies, because this can also be an early sign of systemic disease. And then dental pain or issues, asking about tooth pain or dental problems, because dental health is closely linked to nutrition and infection risk. Untreated dental issues can really lead to serious complications. And then asking about their last dental visit to help assess preventative care and access to care. Difficulty chewing, asking about any pain, missing teeth, jaw issues, because this can directly impact nutritional status. And then changes in taste, which can be related to medications, infection, or neurologic conditions. Red flags here would be dysphagia, persistent hoarseness, and non-healing oral lesions. So now we're getting into objective information. So starting with inspection of the head and neck, and remember, inspection always comes before palpation. So we're inspecting the skull and the scalp. We're assessing the size and the shape, if there is symmetry, any visible lesions. You're looking for anything that's uneven or abnormal. Bumps, lumps, swelling, and discoloration. We want to scan with our eyes for any masses or lumps, swelling, bruising, or trauma, any color changes. We also want to know any abnormal hair growth patterns, comparing both sides. Inspecting the hair, we want to look for distribution. Is it even versus patchy? Feeling the texture, is it dry, oily, or brittle? And yes, we also want to look for any critters like lice or nits. Part the hair so that we can actually see the scalp. Inspecting the neck, assessing again here for symmetry. The neck should be symmetrical with no visible swelling or asymmetry. Alignment of the trachea, that is midline, because deviation of the trachea can indicate serious conditions like pneumothorax or masses. And then we are looking for masses, any visible lumps, which can indicate enlarged lymph nodes or thyroid enlargement. So at this stage, we're really looking for what's normal versus abnormal. And inspection is going to give us our first clues even before we touch the patient. Now, talking a little bit about tracheal deviation, because this is a high yield must know concept. So when you assess the trachea, again, it should be midline. So any deviation would be abnormal, and it can indicate serious pathology. If it is deviated, we want to know which direction the trachea is shifting and why. Think of it as either being pulled or pushed. Deviated toward the affected lung. So if the trachea shifts toward the problem side, it's being pulled. And so often this is caused by atelectasis, where the lung has collapsed, pleural fibrosis, or sometimes a lung has been removed. But these conditions are going to create a loss of volume, so the trachea gets pulled towards that side. Whereas deviation away from the affected lung, so if the trachea shifts away from the problem side, it's being pushed. Causes would include pneumothorax, pleural effusion, or potentially a large tumor or mass. And these conditions increase pressure or volume, which pushes the trachea to the opposite side. So if you notice tracheal deviation, this is an emergency. It can cause respiratory distress. So immediate intervention is going to be necessary. And how do we assess this? We want to use our fingers to palpate the trachea in the substernal notch. We want to check if it is centered between the sternocleidomastoid muscles. I'm so sorry. So again, we want to think if it's pulling toward or pushing away and what that would mean. Now we're moving from inspection to palpation, and this is where we actually are going to feel for abnormalities. We always want to be gentle and systematic and compare both sides. So let's start with the scalp and skull by palpating. We want to use our finger pads and assess for the contour. Is it smooth? The skull should feel smooth and consistent with no depressions or any unexpected protrusions. It should be symmetrical on both sides because differences here can indicate trauma or even abnormal growth. We want to ask the patient if they're feeling any tenderness as we palpate. Could suggest infection, inflammation, or injury. Temporal artery, we're palpating this both sides, and we're assessing the pulse and tenderness. This is important in older adults. Tenderness here can indicate temporal arteritis, which can affect vision. Now, moving down to the neck, which is a big part of the assessment, we are palpating the thyroid gland. We're assessing the size, shape, and symmetry. Normally, it may not be easily palpable, but enlargement or nodules may indicate thyroid disease, so we always want to be able to palpate the thyroid gland. Lymph nodes, we're palpating them on both sides. We're using a systematic approach. We're assessing the size, mobility, tenderness. Normal nodes are small, mobile, and non-tender. If they are enlarged or fixed, it may indicate infection or malignancy. Now we're focusing specifically on lymph node assessment, which is a key part of the head and neck exam. So our technique, we are using the pads of our fingertips, not the tips. We're palpating gently in a circular motion. We're always comparing both sides simultaneously, which helps us detect if there is any asymmetry. In healthy patients, lymph nodes are not palpable at all, so if you do feel them, they should feel like small, soft, or slightly firm beads that are mobile and non-tender. Abnormal findings, we want to pay attention to any nodes that are enlarged, any tenderness, which often indicates infection or inflammation, if they're hard or fixed, which is more concerning with possible malignancy. And again, we want to follow a consistent sequence every time with a systematic approach. We will start with the preauricular to the posterior auricular, the mastoid, occipital, tonsillar, submandibular, submental, anterior cervical, posterior cervical, and then supraclavicular. Supraclavicular nodes are especially important. These should not be palpable in a healthy patient, and if they are enlarged, we really want to think about possible malignancy. So don't just note lymph nodes are present. We want to interpret the size, consistency, mobility, and tenderness if we do feel any lymph nodes. Because again, we're checking for any infection, cancer risk, or systemic illness. And this slide helps us move from assessment findings to clinical interpretation, which is the key for our clinical judgment. Lymphadenopathy, which means enlarged lymph nodes. This is a finding, not a diagnosis. So we always want to ask ourselves, why are the nodes enlarged? Lymphadenitis, which refers to inflammation or infection of the lymph nodes. This is when those nodes are typically tender, warm, possibly red and swollen. It's often seen with localized infections. And then infection with lymph nodes that are actively fighting pathogens. You'll typically see rapid onset of tenderness and large nodes, sometimes bilateral or generalized swelling. But we can connect this back to systemic symptoms like fever or fatigue. Some examples include viral, mono, sometimes bacterial localized infections, sometimes even systemic infections like tuberculosis or HIV. We see in infected lymph nodes that become, overwhelmed with swelling and are painful. And then again, how many times have I said this, but malignancy, where our nodes tend to be firm or hard, non-tender, fixed, and slowly enlarging. And it may also involve multiple nodes. Now we're focusing on the thyroid gland, which plays a key role in metabolism, growth, and energy regulation. So the thyroid sits anterior to the trachea, just below the thyroid cartilage. It has two lobes, a right and a left, and it's connected by the isthmus. It moves upward when the patient swallows, and this is important for assessment. So we start by inspecting the neck from the front. We want to ask our patient to swallow a sip of water. We want to watch for any enlargement, any asymmetry, any visual nodules on the thyroid. And then we're palpating, and the thyroid is best palpated from behind the patient. So we want to place our fingers on either side of the trachea from behind. We want to ask the patient to swallow and feel the thyroid rise under our fingers. And when we're palpating, we're assessing the size, shape, symmetry, consistency, and any presence of nodules. In many patients, the thyroid is not palpable, or it's very small, smooth, and symmetrical. It should feel soft, non-tender. We should be concerned if we feel any enlargement, like a goiter, any nodules. We might require further evaluation. If there's any firm or hard consistency, tenderness. So if we detect any of that on our assessment, we definitely want to bring it up and let the provider know. And we're always connecting that back to symptoms like any weight changes, heat or cold intolerance, any heart rate changes, which can help us determine if the patient has hyperthyroid versus hypothyroid patterns. So again, this is our hands-on skill, what I just went over for the palpation of our thyroid. These are just, again, the steps. This slide is all about what should make you stop and escalate care. And these are not normal findings, so things we're not going to ignore. So the worst headache ever, or new headache after age 50. We also want to watch for associated symptoms like vomiting, neurologic changes, any loss of coordination, stiff neck. This can indicate stroke, meningitis, or any intracranial bleed. Neck pain, especially concerning if this is severe, associated with fever or stiffness. We want to think infection, trauma, or neurologic involvement. Lumps on the neck that have been there for greater than 3 weeks. They need to be evaluated, especially if it's not improving with treatment. Any red flags with our lymph nodes, again, we talked about that a lot just now. So enlarged, non-tender, hard, and fixed. concerning for malignancy. Voice and swallowing changes, so chronic hoarseness that's been going on for greater than 6 weeks, or any difficulty swallowing, those things are not normal. They could indicate tumor, neurologic disorder, thyroid enlargement, other processes, neurologic deficits, so things like facial drooping, ptosis, or asymmetry. We want to think stroke or cranial nerve dysfunction. Those things are urgent. Any unexplained swelling, especially in the neck or face, could indicate infection, allergic reaction, obstruction, or mass. And then sleep apnea, severe snoring. This would impact oxygenation and cardiovascular health, so that needs follow-up. And then oral lesions, any white or red lesion lasting greater than 6 weeks is concerning. Leukoplakia or oral cancer, especially important in patients with tobacco or alcohol use. Moving on to ear assessment. So we have our inner ear anatomy, which will help us understand how hearing and balance actually work. We want to think of the ear in 3 parts. We have our external, middle, and inner ear, which is today's focus. So the ear is responsible for hearing and balance, as we said. So we have our cochlea, which is the spiral-shaped structure, and its job is to convert sound vibrations into nerve impulses, and these signals are sent to our brain via the acoustic nerve. Then we have our vestibular system, which helps us with balance, which includes the semicircular canals and the vestibule. And then we have our semicircular canals, which detect rotational movement, like when you turn your head. They help maintain balance and coordination. And the vestibule detects linear movement or positioning of the head, so things like standing or tilting your head. And then cranial nerve 8, which is our acoustic or vestibule or cochlear. This nerve helps carry hearing signals and balance signals. So damage here can affect both hearing and. Okay, now we're focusing on the subjective history for the ears, so what the patient is going to tell us. And this is critical because many ear conditions are identified through history first. So we want to ask about any past ear infections, especially the frequency, when they occurred, any complications, if they've had recurrent infections, which can lead to hearing loss or structural damage. Always wanting to review medications because some are ototoxic. Examples would include certain antibiotics like aminoglycosides, loop diuretics, which can cause tinnitus, dizziness, and hearing loss. Asking about immunizations, especially in children. Vaccines like pneumococcal and influenza help reduce ear infections, believe it or not. Noise exposure, we're asking and assessing for occupational or recreational noise exposure. Chronic exposure can lead to hearing loss. We want to ask about their work environment, headphone use, concerts, or loud hobbies. Then allergies. Allergies can contribute to eustachian tube dysfunction and fluid buildup, which can impact hearing and increase infection risk. And then ear cleaning practices. We want to ask our patients how they clean their ears, noting we should not use Q-tips that go directly into the ear canal. Improper cleaning can cause trauma and also earwax impaction. And then reviewing of systems, we always ask about key ear symptoms like ear pain, drainage, tinnitus, and hearing loss. Now, ototoxicity, this is an important concept because it's something we can prevent or catch early as nurses. And ototoxicity refers to damage to the inner ear caused by medications or chemicals, which can affect, again, hearing and balance. Damage can be temporary or permanent. So patients may experience hearing loss, tinnitus, or dizziness or vertigo. And the goal is to that early recognition. We always want to ask our patients, are you having any ringing in your ears, any dizziness, any changes in hearing? Common ototoxic medications, we want to use the mnemonic calm ear. So C for cisplatin, A for aminoglycosides like gentamicin, tobramycin, L for loop diuretics, M for malaria drugs, E for erythromycin, A for aspirin in high doses, R for vancomycin with red man syndrome association. And then environmental causes, there's not just medications that can cause ototoxicity. Heavy metals like mercury, lead, and arsenic can also cause ototoxicity. So as nurses, we want to connect our medication history and symptoms, especially patients with any hearing loss. So in our assessment, we are inspecting the ears, we're looking at the size, shape, and symmetry, the condition of the skin, if there is any tenderness, assessing piercings for any inflammation, redness, tearing, keloid development, any swelling or redness for otitis externa, any hematoma, traumatic arcular hematoma, cauliflower ear from boxing or, fighting, and then skin cancers. And then after inspection, we're moving to palpation of the external ear structures. We're assessing for pain or abnormalities. We start with the pinea or the auricle by gently palpating the helix, lobule, and posterior ear, and we're assessing for any tenderness, masses, or swelling. And it should feel firm, mobile, and non-tender. We also want to push on the tragus, and when we're pushing on the pain when pushing on the tragus, that's not normal, and this is highly suggestive of that otitis externa, or also known as swimmer's ear. We can also gently pull the auricle up and back in adults. Any pain with movement of the ear, we also would support external ear canal inflammation. And in a complete health assessment, you should know how to use an otoscope, but in practice, you'll use it when it's clinically indicated or in certain settings like primary care. So this is an advanced assessment skill using the otoscope to visualize the ear canal and tympanic membrane. So before using it, we want to talk about the components of the otoscope. So we have a light that provides us illumination, the speculum, which is the part that is inserted into the ear, and then a magnifying lens, which allows us to visualize the structures of the inner ear, and the head, which contains the lens and the light, and the handle, which we have, which is what we grip and hold. So we always choose the largest speculum the patient can comfortably tolerate, which gives us the best view. So safety first, this is, we want to stabilize our patient by bracing one hand against the patient's head to prevent any injury if our patient moves suddenly. We never want to insert without visualizing. Blind procedure risk, we don't want to do that. It's positioning, so for adults, we want to pull the ear up and back, and in children under 3, we want to pull the ear down and back, which straightens the ear canal for our proper visualization. And what we're looking for as we insert the otoscope, we're assessing the ear canal for any redness, swelling, earwax, or discharge. And we're also looking at the tympanic membrane for color, position, and the integrity. So once you're in with the otoscope, this is where you're looking at the tympanic membrane or eardrum. And before we focus on the details of this, we always want to ask, does it look intact? Is it pearly gray and translucent? And can I see the landmarks clearly? And the landmarks are in this picture here. So this is the normal tympanic membrane. So any deviation from this would be abnormal, and we would report. Now we're going to apply what we just learned and look at common middle ear pathologies you'll see on exams and in practice. So we have acute otitis media. This is an infection of the middle ear. It's very common, especially in children, and what we'll see is bulging red tympanic membrane, and the landmarks are often not visible, as you can see on the left picture. The first picture, what patients normally report: ear pain, fever, irritability, especially in children. And what we're looking at is a bulging tympanic membrane, which equals infection, and we want to think about putting the patient on antibiotics. Otitis media with effusion. This is not an active infection. This is fluid behind the eardrum. So what we'll see is yellow amber fluid, possible air bubbles. The tympanic membrane may look dull or retracted, and patients will report a fullness, hearing loss, usually no fever or no acute pain. So no antibiotics are needed. And then chronic otitis media, this is a long-term or recurrent infection. What we'll see is a perforated tympanic membrane, drainage, thickened or scarred tympanic membrane, and patients would report recurrent infections, hearing loss, persistent drainage. The clinical concern here is a risk for hearing impairment and complications if it is untreated. Now we're looking at more serious ear pathologies. These are less common, but very important to recognize. Cholesteatoma. This is not a tumor, even though it sounds like one. It's an abnormal collection of keratinized skin cells in the middle ear. And what we see is a white, pearly, or yellowish mass behind or within the tympanic membrane. It may look like debris or buildup. The patient would report chronic foul-smelling drainage, hearing loss, recurrent ear infections. And why this matters is because it can erode bone and damage structures of the ear, and it can lead to hearing loss, dizziness, even serious complications if untreated. Perforation of the eardrum. This is a hole in the tympanic membrane. What we're going to see is a visible opening in the tympanic membrane, as you can see in the picture. You might also see drainage, redness, and possible infection. So causes of this would be infection, where we have pressure buildup, trauma from Q-tip or foreign objects, barotrauma, sometimes from flying or diving, and then loud noise. And what the patient would actually report is sudden relief of pain after rupture, drainage, hearing loss, possible tinnitus. Most small perforations really heal on their own, but patients should keep their ear dry, avoid inserting anything into the ear because that could be dangerous for infection. Now moving on to eye assessment. So we're starting with inspection of the eyes, which gives us a lot of information before we even test our patient's vision. We're assessing their eyebrows for symmetry and hair distribution. Loss of the outer third of the eyebrows, we want to think hypothyroidism. We also want to note any lesions or skin changes around the eyebrows. Eyelids and lashes, we want to look carefully at the lid position and structure. Sometimes we see ptosis, which is drooping eyelid, can be a neurologic issue. An entropion, where the lid turns inward and the lashes can irritate the cornea. Ectropion, which the lid turns outward, where we see some dryness and tearing. We're also assessing for any lesions, xanthomas, which are yellow plaques, indicating lipid disorders. We're also looking at the conjunctiva and sclera by pulling down the lower lid to inspect. And what we're looking for is the color. If the patient's conjunctiva is pale, we're thinking about anemia. If it's red, we think of infection or inflammation. Yellow, sclera, we think of jaundice, and so we think about liver disorders. So we're checking for color, consistency, any drainage or discharge. And then the lacrimal apparatus, which is the inner canthus area, we're looking for any swelling, excess tearing or drainage. Blocked tear ducts can cause watery eyes. The cornea and the lens should be clear and smooth, and the lens should be transparent. Any abnormal findings would be cloudiness, which could indicate cataracts, and then scratches like corneal abrasion, which can be really painful. And then we're also looking at the eyes, the iris, and pupil, assessing the size, shape, and symmetry. They should be round, equal, and reactive. So let's look at some classic eye findings you should be able to recognize clinically. Arcus senilis. This is a gray-white ring around the cornea. It's common in older adults. It's a normal part of aging. In younger patients, we want to think about hyperlipidemia. coloboma. This is a congenital defect. You'll see a keyhole-shaped pupil. This can be present at birth. It can affect vision depending on severity. It may be associated with genetic syndromes. Exophthalmos, this is a protrusion of the eyeballs. We want to think about Graves' disease, which is hyperthyroidism. And what we'll notice is a wide staring appearance, lid retraction, possible dryness or irritation. A stye, this is a localized infection of the eyelid gland. It looks red, swollen, painful on the eyelid, usually caused by a staph infection, can be treated with a warm compress. So another advanced skill here for our eyes, ophthalmoscope. This is to look inside the eye, specifically at the retina, blood vessels, and the optic disc. This is one of the few times we can directly visualize vascular and neurologic health. And what we're looking for is a red reflex. So normal would be a reddish orange glow when we're looking at the eye through this ophthalmoscope. Abnormal findings could indicate cataracts or retinal detachment. We're also looking at the optic disc, where the optic nerve enters the eye. Normally, this would be round, yellow yellow to orange shade or color. With sharp borders. Abnormal would be we see blurred margins, and then we're also looking at the retinal vessels. So we are following the vessels out from the optic disc, and we're looking at the color crossing patterns, and any narrowing or nickeling changes here can reflect chronic conditions like hypertension or diabetes. And then the macula, which is responsible for central vision, you'll usually assess this last because it's really uncomfortable for patients. So you're like directly into the eye. So how to perform this, we're going to dim the lights. We're going to use our right hand and right eye for the patient's right eye and vice versa. And we want to start about 10 to 15 centimeters away. Again, we're looking for that red reflex, and we want to move in slowly while keeping the reflex in view. We want to start with large round light on the ophthalmoscope and tell our client to look at an object behind the wall, on the wall behind us. And we want to use our right eye to examine the client's right eye and the left to the left. So we want to place our hand on the client's forehead, look for that red reflex, and move in using red reflex as a guide. And we want to look at the optic disc and assess those blood vessels, macula, and retina. Onto the nose and sinuses. Starting with inspection. So when we assess the nose, we're looking at both the external structure and the internal structures. Starting with the external, we want to look at symmetry, size, any deviation, anything asymmetrical or deviated could affect airflow. Then we're looking at the internal portion of the nose. So positioning wise, you're going to want to have the patient tilt their head slightly back. Use a nasal speculum if available, which can help us actually visualize structures. And what we're looking at is nasal flaring as we're looking at the outside of the nose. This is a big respiratory red flag, especially in children. We want to think about increased work of breathing. We're looking at the mucosa. Normal color would be pink and moist. Abnormal would be pale or red and inflamed. Exudate, so like any drainage. We're looking at the color and consistency. Looking for lesions like ulcer sores or abnormalities, which can indicate infection, trauma, or malignancy. Polyps, these look like pale grape-like growths, and they can be associated with chronic allergies or asthma. And then bleeding, we're looking for sites of recent bleeding, very common with epistaxis. Septal deviation, the septum should be relatively midline, and deviation can cause obviously difficulty breathing or chronic congestion. So the slide shows what it actually looks like to perform an internal nasal exam using the nasal speculum. We're going to gently insert it into one nostril, angle it slightly upward, not straight back, to avoid the septum, and we're going to open it slowly to visualize any structures. Again, we're being really gentle here. This can be sensitive. The nose tends to be very vascular. So we're, the speculum is going to allow us to visualize the septum, the turbinates, the deeper mucosa, and any abnormalities much better. This slide highlights two important structural abnormalities of the nasal septum that you may see in practice. So septal deviation on the left image, which means that the septum is shifted off the midline, as you can see. One nostril appears narrower than the other, so airway may be partially obstructed. This can be congenital or can be from trauma like broken nose, but patients may report chronic congestion, difficulty breathing through one side, and recurrent sinus infections. And then septal perforation on the right image. This is a hole in the nasal septum, which is not normal. You'll see visible opening between nostrils. Light may pass through, as shown here. Causes of septal perforation: trauma, like picking your nose frequently, or injury, chronic cocaine use, we see often, long-term nasal spray use, especially steroids, and infection or autoimmune disease. So signs and symptoms associated with this: we could see crusting, bleeding like epistaxis, whistling sound when breathing, and possible discomfort. So always check if the septum midline and is it intact. Examination of the sinuses. So when we assess the sinuses, we're mainly looking for signs of inflammation or infection like sinusitis. So start by inspecting by looking at the areas over the frontal sinuses like forehead, or maxillary sinuses like the cheeks. We're assessing for swelling, redness, and facial asymmetry. Next, we're going to palpate the sinuses, and we're pressing upward under the eyebrows. For the maxillary sinuses, we're pressing over the cheeks. We want to ask our patient, does this feel tender? Abnormal findings would be tenderness, possible sinus infection. This is one of the most important findings on this type of exam. And then percussion, we can also tap over the sinuses. This isn't always done in practice, but it can help us identify pain or pressure. Patients with sinusitis often report facial pain, pressure, headache, nasal congestion, and thick nasal drainage. But red flags would be severe pain, swelling, or fever, which can indicate more serious infection. This part of the exam focuses on the mouth and throat, and it can tell us a lot about infection, hydration, nutrition, and systemic disease. So assessment of the oral pharynx. So when we're doing this, we're inspecting the lips, buccal mucosa, which is the inner cheeks, the hard and soft palate, the tongue, the gums, and the teeth. And what we're looking for is any lesions or ulcers, inflammation or redness, or leukoplakia, which is white patches, any masses or exudate, petechiae, dental issues like missing or decayed teeth, and then bleeding gums. We're also smelling for halitosis. We can gather information just from smell, believe it or not. So examples, we might smell fruity or acetone breath in our patients with diabetes, and we want to think about diabetic ketoacidosis, which, maybe you don't know what that is, but it will come later with time, trust me. Ammonia, if we smell ammonia, it may indicate possible renal failure, possible cirrhosis. These can be subtle smells, but again, very important clinically. And then setup matters for assessment of the oral pharynx. Always use good lighting. Assess patients or ask patients to remove their dentures or appliances so that we can fully assess the mouth. Next, we're going to palpate the mouth for lesions, any blocked salivary ducts. Always wear gloves at this point, of course. And then throat inspection, we can use a tongue depressor to visualize the pharynx, tonsils, and soft palate. We're looking for any redness, swelling, exudate, and looking at tonsil size. We want to have the patient say ah to assess the uvula for movement, and then symmetry. Any red flags would be white or red lesions that don't heal, any significant swelling or airway obstruction, and then asymmetry of the uvula. So, tongue and buccal mucosa, when we're assessing these, we're looking for any early signs of infection, irritation, or even malignancy. Starting with color, is the mucosa pink and moist, or is it pale or red and inflamed, or white? Those things are abnormal. We're looking at ulcers, any open sores, any white patches, could be thrush or leukoplakia, plaques, so thickened areas on the mucosa, nodules like raised lumps or masses. This slide shows gingival hyperplasia, which is an overgrowth of the gum tissue. Notice how the gums look thickened and enlarged and may cover part of the teeth. They might appear swollen or bulbous. A key cause, this can be medication related. Phenytoin or Dilantin, which is a seizure medication, is known to cause gingival hyperplasia, but we also see medications like calcium channel blockers like nifedipine, cyclosporine. This isn't like a huge red flag, but it can cause other issues. So some things we want to talk to our patients about with gingival hyperplasia is good oral hygiene, to make sure that plaque doesn't build up. It can lead to bleeding gums, increased risk of infection, or, on the other side of things, cosmetic concerns. So again, regular dental visits, good oral hygiene, patients that are on these high-risk medications, we want to watch out for gingival hyperplasia. So now we're going to talk about developmental variations in head, ears, eyes, nose, and throat, because things like pregnancy, where we are seeing normal physiologic changes with pregnancy, but might not be normal for someone who is not pregnant, right? So we see thyroid changes. Often the thyroid is enlarged slightly during pregnancy because there is increased metabolic demand or hormone stimulation. So you may even hear a thyroid bruit due to that increased blood flow. So we might see mild enlargement, and this is totally normal for someone who is pregnant. We might also see skin pigment changes, like melasma. So like we call that the mask of pregnancy, and linea nigra on the abdomen. So these are due to normal hormonal pigment changes. Also nasal changes, hormones plus increased circulation. We see vascular congestion, which can lead to nosebleeds, nasal stuffiness. It can look like a cold, but it's totally hormonal. Also, gum changes. Gums can become hypertrophied and more vascular, and so we can see swollen gums, bleeding with brushing. Patients that are pregnant have increased estrogen and progesterone, which leads to vascular changes. With neonates, the fontanelles, newborns have soft spots where the skull bones haven't fused yet. So we see the anterior fontanelle, which is diamond shaped. This closes at about 12 to 18 months. And the posterior fontanelle, which is smaller, it closes at about 2 to 3 months old. So when we are assessing the head, these fontanelles are normal. We are assessing them for that they are flat and soft, which is normal. If they become sunken, we're thinking about dehydration. If they're bulging, we think about increased intracranial pressure. But you'll learn more about this when you get into maternity and pediatrics next semester, or whatever semester you will have maternity and peds. Newborns are also nose breathers, and this matters because any nasal obstruction can cause respiratory distress pretty quickly. The other thing we think about with neonates is nasal flaring, flaring of the nares. indicates increased work of breathing, and we think about respiratory distress and hypoxia, and it often occurs with grunting and retractions and tachypnea, but that's a huge red flag. So any bulging of the fontanelles, sunken fontanelle, nasal flaring, cyanosis, any poor feeding or lethargy. Children, um, children frequently rub or push the nose upward, and so sometimes we see these transverse line crease across the nose. It's because of that chronic upward wiping motion. We want to think about allergic rhinitis. We also have associated findings like dark circles under the eyes in children, where we call this allergic shiners. They are also mouth breathers, and they tend to have a lot of clear nasal drainage going on. So if you see that across the nose, we want to think about allergies, not just a cold. Foreign bodies in the nose, very high yield in kids. Kids put things in their nose. It's very common. Red flags with a foreign body, any unilateral nasal drainage. This can be a big clue. Foul smelling discharge or possible blood tinge drainage. And we also want to keep an eye on their respiratory, if they're having respiratory distress. Older adults, with aging, you often see increased earwax production, which can lead to conducive hearing loss. We also see presbycusis, which is sensorineural hearing loss from degeneration of the organ of Corti. So this is difficulty hearing high-pitched sounds. That comes from an inner ear problem, or potentially blockage with earwax. Eyes, aging affects multiple parts of vision, so we can see decreased tear production with dry eyes, decreased visual acuity, decreased night vision, a loss of peripheral vision, and those things are a normal part of aging. Also common conditions in older adults, cataracts, which is they have cloudy lens and blurred vision, glaucoma, which is increased intraocular pressure, which can lead to peripheral vision loss. Other random assessment findings. The thyroid may feel more nodular or irregular because of long-term structural changes. Patients that are older, we also see an increased incidence of hypothyroidism. So any new firm fixed nodules need evaluation, but again, the thyroid may feel more nodular or irregular in older patients. Range of motion, we want to be cautious when assessing neck movement here because of arthritis or cervical spine degeneration. So we want them to move very slowly and gently, and we want to stop if any pain occurs. Skin changes in the face and neck. We see thinning skin, wrinkling, loss of elasticity. Skin is more fragile, so we're assessing more carefully. Many older adults, they might not have teeth. They might have dentures, so this could affect speech, nutrition, and our oral assessment findings. Remember, we're always removing dentures for our full exam of the mouth. Decreased salivation, saliva production decreases with age, and it can lead to dry mouth, which is xerostomia, which increases the risk of dental caries and oral infections. So being aware of that. And then cultural considerations of the head, ears, eyes, nose, and throat. So retinal color can vary based on pigmentation. So don't expect every retina to look the same. Variation is going to be normal. Sclera color, it's not always bright white. Some have bluish hues, brownish, yellowish tint, or true yellowing, which is jaundice, which is not normal. And then disease risk patterns. Caucasian patients have increased risk of age-related macular degeneration, and then myopia. African American patients have an increased risk of glaucoma. Um, Cerumen difference, so earwax consistency varies genetically. We have wet cerumen, which is more common in Caucasians and African American patients, where we see dry earwax, more common in Asian and Native American patients. Otitis media risk, so we have increased incidence in Native American populations and Alaska Native populations and Inuit populations, but this is likely related to the anatomy and environmental factors. So cultural competence in our assessment means knowing what's normal for that patient, not what we just see in the textbook, because likely we see a lot of Caucasian pictures and examples in our textbooks, unfortunately. And then finally, health promotion. So head injury prevention, we want to think about safety first, always talking about helmets when using a bike or doing sports, definitely riding motorcycles, fall prevention, especially older adults, talking to patients about stopping smoking or chewing tobacco, which increases the risk of oral cancer and periodontal disease. Alcohol use, we know excessive alcohol use can lead to oral cancer and nutritional deficiencies. Sunscreen on our face, neck, and ears to prevent any skin cancers. Protective eyewear when we're working, doing sports or yard work to prevent corneal abrasions or eye trauma. And then regular eye exams for things like diabetes, hypertension, or in our older adults to screen for glaucoma, retinopathy, or macular degeneration. Dental care, definitely flossing, preventing gingivitis, periodontitis, and then any systemic complications related to gum disease. Controlling noise exposure with headphones, concerts, and occupational exposure. If we have to shout to be heard, it's really too loud. Ear cleaning, avoid cotton swabs inside the ear canal. Nothing smaller than our elbow should be in our ear. And then ototoxic medications, key ones to know are the aminoglycosides, NSAIDs, aspirin, also I would say loop diuretics. We want to teach our patients to report any tinnitus, dizziness, and hearing loss. All right, we're just about an hour. I know that was a lot, but I will see you in class to do our actual assessments. Hope you enjoyed. Have a wonderful day. I'll see you in class.